Firstly, I'd just like to welcome everyone who's participating in the webinar, because we've got some excellent kind of speakers and content that we're going to share this afternoon. But also welcome to everyone who's shown an interest in this topic. This is the first time we've run this Stop Smoking London LGBTQ+ week. And to see so many people who are interested in this actually is fantastic, and spread the word more widely as well as has been suggested with staff networks and beyond. As I say, this is being recorded and it will be on the London Tobacco Alliance website. Just to start off, my name's Tracy Parr and I'm the Programme Director for the London Tobacco Alliance and Stop Smoking London. Stop Smoking London is our citizen-facing website and service. London Tobacco Alliance is much more a stakeholder organisation. And what we're going to do today is go through a number of presentations around the issues that face the LGBTQ+ community generally, and what causes them possibly to have higher rates of smoking, some of those drivers. We're going to look at the campaign that we've developed with LGBT Hero. We're going to have an overview of the Smoke Free app and how that offers LGBT-friendly support to people from the community. And then we're going to hear from two London examples of working with the community at a very local level. So we've got national stuff, we've got London stuff and local stuff, and I think that's really, really helpful. And I'm just going to share a slide around what we'd like you to do around some of our socials today. So we are very heavily on socials. You can see here, let me just move that over. You can see here we're on Facebook, and we're on TikTok, and we're on Insta, as well as being on LinkedIn. So please do, Nikki's done a great slide for us to alert you to what we want you to do, which she's not going to share, I'm afraid, but it's gone through. There we go. So this is the kind of things we want you to do: to follow us, tag us, repost, duet and stitch our videos on TikTok, and just let's get some kind of social media energy going here, because it really does help to promote this really important topic. So I'll stop sharing now, and it's with enormous pleasure that I'd like to welcome Michael Brady, who's the National Clinical Director for LGBTQ+ health in NHS England. I have to confess, I didn't even know we had a National Clinical Director, and I'm delighted that we do, and that we've got a place where we can have a focus on this group of people who have really specific health needs and are often ignored in health settings. So I'm going to hand straight over to you, Michael, if that's all right.
Thank you, Tracy, and thanks for the invite. And it worries me that people don't know, so that's a B- for me. Must do better in terms of getting the word out about the work that I do. Anyway, thanks for the invite to come and talk today. I'm just going to, hope this works, share my screen. Please do shout if this isn't working. Let me get that onto presenter mode. Why is that not doing it? There we go. So hopefully you can see that, and shout at me if the slides don't move, because I can't see you anymore. So I'm just going to get us going, I think, really with some top level thoughts and data around LGBTQ+ communities in the UK, with a particular focus on what we know about mental health, minority stress, and how that links to issues like smoking, substance misuse, etc. By showing you a little bit of data. But just to start from the beginning when we're thinking about these communities. So for the first time in 2021, the census asked questions about sexual orientation and gender identity. So really for the first time gave us an idea of the size of the population of people who self-identified as LGBT+. This slide focused just on those with minority sexual orientation, so identified as lesbian, gay, bisexual or other. And overall, which you can see at in the top sort of blue and green graph in the 2021 census, about 3% of respondents, it's about 1.5 million people, identified as lesbian, gay or bisexual. About 750,000 of those identified as gay or lesbian, and about 600,000 identified as being bisexual. And we can see from other sources of data that over time, which I guess is a good thing, and a reflection of, to some degree, changing societal attitudes, the proportion of the population that are comfortable to identify as lesbian, gay and bisexual has slowly increased. And we see age differences, again, not surprisingly. So a larger proportion of younger adults or adult respondents to surveys identify as being lesbian, gay and bisexual compared to older adults. I'm going to touch on, and certainly when I get to a little bit further through the talk, intersectionality. It's an important concept to keep in mind all of the time, not least because the LGBTQ plus community itself is deeply heterogeneous and intersectional, with obviously a mixture of sexual orientations and gender identities. So although we use the acronym for ease and speed, always remember that it is a very diverse population with very diverse needs and experiences within that acronym. And then obviously thinking about the the importance of intersectionality with being LGBTQ plus and having other characteristics, which often accumulate, certainly when we're thinking about health inequalities or the impact on experience or outcomes. So an example here from the census of one aspect of intersectionality, that between being LGB and being disabled. So interestingly, a smaller proportion, 8.8% of census respondents who identified as being lesbian, gay and bisexual also identified as being disabled, compared to 20% of the overall population. Now that in itself probably reflects the younger age profile of those who identify as lesbian, gay and bisexual. But the converse of that is that when you do look at the younger respondents, you get greater reports of having a disability. So in the 16 to 24-year-olds who identified as lesbian, gay and bisexual in the census, they were much more likely to report having a disability when compared to the overall population of England and Wales for the same age, and that probably reflects the greater prevalence of mental health problems in younger LGBT people. So that's what we know about the lesbian, gay, bisexual population. As I said, similarly, for the first time in 2021, the census had a question about gender identity. So this was a voluntary question, as was the sexual orientation question. And the question was, is your gender identity the same as your sex registered at birth? And 0.5%, which represents about 262,000 respondents, stated that their gender identity was different from their sex assigned at birth. And you can see a breakdown there on the right. It's about 50,000 identified as trans women and 50,000 identified as trans men, about 0.1% for each in terms of as a proportion of the overall respondents. So that starts to give us an idea of the numbers of people in the population, and also usefully starts to give us some data, both not just nationally but also locally, when we can think about people who would need to access our services on a local or regional population level. Now, just a couple of slides about mental health. not least because, and I probably don't need to say this to this audience, there is a really strong link between, poor or worsening mental health, increased likelihood of smoking, and also increased likelihood of alcohol or other substance misuse. But as a general rule, and I think whilst we have sometimes patchy or paucity of data, where we do have data, whether it's in surveys, in clinical data sets, or in academic research, pretty much across the board and pretty much for every single type of mental health problem, whether that's mood disorders, eating disorders, psychotic illnesses, etc. They're higher, and usually to at least a factor of 2 and 3 in in lesbian, gay, bisexual, trans, non-binary and gender diverse people when compared to heterosexual or cisgendered people. So a couple of examples of studies here. So the Stonewall survey, I think this is of about 5,000 people. It's a few years old now, but I don't think that it's any less relevant for that. So half of the respondents to that survey had experienced depression, and 60% had experienced anxiety. When looking at younger respondents, about 1 in 8 had attempted to take their own life, and about half of trans respondents to the Stonewall survey had thought about taking their life. And when we focus particularly on suicide and self-harm, we see similarly high levels, whether it's in self-reported surveys or in clinic-based data reporting or research, of around 30 to 60% of trans people having self-harmed in the last year, a significant majority, in one survey at least 80% of trans people having thought about ending their life at some point, and very high similar levels, particularly when you look at the younger age group, to the 16 to 84-year-old LGBTQ plus people, and particularly trans, non-binary and gender diverse youth. I want to just show this just briefly because I think it kind of correlates, if you like, with some of that other data, and also starts to show us a little bit not just about mental health, but also about smoking practices. So I'm just going to show some data from the GP Patient Experience Survey, the National GP Patient Experiences Survey. This is the largest of the NHS patient experience surveys, usually with about 700,000 to 800,000 responses each year. And in 2022, for the first time, we put questions in there about gender identity. They'd had questions about sexual orientation for a few years, but the gender identity questions were new, and this is the questions that went in and are currently in the survey. So a 2-stage question around gender identity, that's question 53 and question 54. So which of the following best describes you, with a number of options, including prefer not to say. And then the secondary question of, is your gender identity the same as the sex registered at birth, with a yes, no, or prefer not to say. So respondents to the first question enabled us to identify people who self-described as non-binary. When you answered no to question 54, that's people who were then identified as being trans, i.e. their gender identity is not the same as their sex registered at birth. And then obviously question 62 gives us sexual orientation. And importantly, with all of these questions, always an option of I would prefer not to say. So this is some data. It's a couple of years old now, but this is the last time that we actually did some really detailed analysis in terms of LGBT plus respondents. We're doing some at the moment actually on the 2024 survey, but this is the last time that we did it and got a lot of more detailed breakdown. So in this year, 2022, there were 720,000 respondents altogether, and within that we had 1,500 people who were non-binary, 1,350 who said that they prefer to self-describe, and that's an important group as well, not least because they often have similarly poor outcomes or greater inequalities. Just under 4,000 trans respondents, and there at the bottom you can see the number of people who are gay, lesbian, bisexual or ticked other. Now, there's a lot of data from this survey, but I'm just going to show a few slides specifically focusing on mental health and smoking. So high reported rates of having a mental health condition in this survey, and we saw an increase when we compared the 2022 data to the 2021 data. So you can see, just if we will go around sort of clockwise from the top, About 30% of LGB patients reported a long-term mental health condition, and that had gone up by nearly 30% since the year before. 45% non-binary patients reporting having a long-term mental health condition, and that had increased from the year before. And again, about a third of trans patients reporting having a long-term mental health condition, and that had gone up by a quarter from the year before. And you can see that displayed here in the bottom right. And I think it's an important thing to note here. So this is looking at the proportion of people who report a long-term mental health condition, 25% in gay and lesbian, higher rates in bisexual people. And I make that point because frequently bisexual people are invisible, forgotten about, and not included. And frequently when we look at the data, their experience is worse than gay and lesbian people. It's often closer to the poorer experience of trans, non-binary and gender diverse people than it is to that of gay and lesbian people. So we need to increasingly be thinking about bisexual men and women more than we do now. And also, the other is important. So that's where people self-describe. And as I said before, you see similarly high rates of mental health conditions, and you get the same in other questions as to when compared to people who self-identified more specifically. So the other group is just as important. We were also able, because of the large sample size, to break it down by age, which I think is important because you do see differences at different age groups. So we've got here the percentage of people who report long-term mental health conditions in trans patients, in non-binary patients, and in patients who are LGB plus for each of these different age cohorts. And you can see, interestingly, a very similar pattern across all of these groups. So pretty much across the board, trans, non-binary and LGB patients were more likely to report having a long-term mental health condition when compared to heterosexual or cisgendered people. But those differences were much greater in the younger age group, 16 to 25. And actually, as you start to get to the older age groups, those lines start coming together. And as I mentioned before, there is such a strong and intrinsic link between poor mental health and smoking habits. So this is smoking behaviors. This is again from the GP patient experience survey. So from 2022, when we did this analysis, you can see that, and actually you haven't got the two lines coming together here, but for all age groups, LGBT plus patients were much more likely to report smoking when compared to cisgender and heterosexual people, and those lines don't come together for all age groups. 13.8% of smokers in all respondents, and around about 20 to 22% of smokers in the LGBT plus groups. Okay, a little bit about challenges for LGBTQ plus communities. We're not going to be able to go into this into too much depth because of the time, but I just wanted to say a few things, both about the general population or our patients and service users, but also about our colleagues and staff in terms of some of the complex reasons why mental health problems are more common for LGBTQ plus people. Minority stress is a complex title that covers a lot of things within it. Just a few examples, though, of the kind of lived experience or the described lived experience of LGBT plus people in this country that impacts on minority stress and impacts on mental health. So from the National LGBT Survey, which was done in about 2016, over 100,000 respondents to this survey, and very strikingly, more than 2/3 of respondents simply said they avoid holding hands with a same-sex partner for fear of a negative reaction from others. And this survey was done nearly a decade ago, and I would wager that figure is higher now. At the more extreme end, we see hate crimes, anti-LGBT plus hate crimes are continuing to rise. From the latest data that we have from 2023-24, 16% of hate crimes were motivated by sexual orientation. So remember, about 3% of the population identify as LGBT plus, and 3% by gender identity, again disproportionately to the 0.5% of the population who identify as trans. And we can't underestimate all of the other the impact of all the other negative, let's call it external environment things, the toxicity of our politics, of our media, particularly social media, of the shifts right, and the anti-LGBT, anti-woke, anti-EDI, and anti-trans specifically rhetoric that all contributes, as well as these examples, to worsening anxiety, depression, and substance misuse, including smoking. Just also to make a point about colleagues, because I think we need to look in as well as look out. We know from the NHS staff survey, for example, that LGBT+ staff consistently report higher levels of discrimination, harassment, bullying or abuse compared to their heterosexual and cisgendered peers. They're much more likely to be thinking about leaving the NHS, and consistently score lower on pretty much all of the questions in the NHS staff survey. And a large survey by the TUC done last year found really high, this is across lots of different workplaces, but found about 20% of LGBTQ+ staff experience verbal abuse in the workplace, 5% physical abuse, and a very high proportion, 80% of trans people experience bullying in work. So there's a lot of challenges which all culminate in worsening mental health for LGBT+ people, and then further compounded by that last bullet point there. This is not just for LGBTQ+ communities, but they experience it just as much as everybody else. But access to mental health services and care is increasingly difficult and challenging, and certainly access to LGBTQ+ inclusive mental health services and care is even harder. Just a few things. I think it's my penultimate slide, and then I'll wrap up. Just thinking both in terms of the services we provide and the support we give to our colleagues or as leaders within organisations. There are simple things that we can think about that can impact on mental health and therefore other issues like smoking or substance misuse further down the line. Being a good listener, being a good ally, being a good support for colleagues, thinking about our responsibilities as service providers and as leaders, and more widely as organisations, about the inclusivity of the approach that we use in terms of the language that we use, the imagery we use, and the policies that we work by, ensuring that at every step, like a stick of rock, you can cut through it and see meaningful engagement with the LGBT+ community on the work that we do and the things that we produce and the services we deliver. Really essential to this is education, training of our workforce to be more LGBT+ inclusive, and visible and accountable leadership and role models also goes a long way to being an inclusive service provider and an inclusive employer. All right, I will just leave that there for a second by way of a brief summary. So just to make some points going back for that first slide, we are, I guess, one good thing in a sea often of not very good things, but certainly the community is becoming more visible, or is certainly more comfortable answering surveys about their sexual orientation and gender identity. But the causes of poor mental and physical health are long and deep-seated and will take time and effort to unravel, as they're kind of embedded in decades often of discrimination and marginalisation. Just as a reminder about remembering intersectional identities who often have compounded inequalities, and the same that is very much true for mental health and smoking. All right, I will stop there. Thanks very much.
Thank you so much, Michael. And it paints a very challenging picture for this population, and addressing one of the kind of impacts of that, i.e. smoking, but other substance use, I think is really important. So so this week is a starting point, not an end point, most definitely. We didn't have a discussion about this, but are you and Tristan happy to take questions together at the end of your two sections? Would that be the most useful? Thank you. Yep. Thank you so much. So I'm now delighted to introduce Tristan Barber, who's a consultant in HIV medicine at the Royal Free. And you've also got a national role, whose name eludes me. I regret to inform you, Tristan. So
no problem at all. Thank you very much, Tracy. No, I'm taking over as the next chair of the British HIV Association from the end of November for a 3-year term. So exciting and nerve-wracking all at the same time. Lovely to be here. Thank you very much. I will just try and share my screen, and just like Michael, hopefully be able to go to full screen.
Yeah, all good.
Thank you very much indeed. So I wanted to talk a little bit about protecting your sexual health and how this can lead to opportunities for us to encourage people from LGBTQ plus populations to protect their overall health. As we've just heard Tracy mention, not only are we thinking about smoking, but also the use of other illegal drugs and other high-risk behaviours. And I think as we see opportunities for people to reduce their risk of sexually transmitted infections in particular, so we have an opportunity to also talk to people about other risk behaviours, including smoking tobacco. So I now can't move my slide. Hang on. There we go. In terms of sexual health overall, we know that from the LGBTQ plus umbrella that lesbian women remain at low risk for most sexually transmitted infections, exclusively lesbian women, I should add. We know that gay and bisexual men who have sex with men have a higher risk for sexually transmitted infections and for bloodborne virus acquisition, but we now have combination prevention techniques available to help reduce these risks, and I'm going to cover some of these briefly. We know that trans and non-binary individuals generally have a higher risk of infections, although this group is not homogenous, and as Michael has indicated, a personalised assessment and realising differences within this group is very important for a risk assessment, and this can be done perhaps best at the moment in an inclusive specialist service. But again, as Michael mentioned, we really want to see the upskilling of all healthcare providers to make sure they can provide this inclusive, non-judgmental service in any point of contact for people from this group who are receiving healthcare. So what about prevention for HIV? I'm sure many people on the call have heard of PrEP. So PrEP stands for pre-exposure prophylaxis. This is at the moment a once-a-day pill taken to prevent HIV, and for most people is most effective when taken every day. It is possible for gay and bisexual men who have sex with men to take event-based PrEP if they know that the time of sex will be predictable, but for most people taking it daily gives them consistent cover, and of course very often sex is not predictable, so this ensures that people are covered for HIV prevention when sex does occur. When taken consistently, PrEP can reduce the risk of contracting HIV by at least 99%. What we actually see in the studies is that for people that have confirmed drug levels in their blood, this prevention is approaching 100%. But overall, because sometimes people might miss pills, the prevention is about 99%. And we know that PrEP is most effective when combined with other prevention tools. Condoms will help, of course, reduce the risk of bacterial sexually transmitted infections, but we'll come on to some other ways to reduce the risk of bacterial STIs in addition to barrier methods. We've also recently seen approved in England and Wales, it was approved earlier in Scotland, an HIV protection injection. This is cabotegravir given every 2 months, a very effective way to prevent HIV acquisition. And we know from the studies that this method is preferred in cisgendered women, but also in trans women for HIV prevention. It's preferred over and above oral tablets, and as a consequence has a higher effect in these groups in particular because they're not at risk of missing tablets. So where are we at with HIV? Well, we know that new diagnoses of HIV fell by 4% across the UK from 2023 to 2024. So you can see 3,169 individuals being diagnosed with HIV in 2023 and just over 3,000 in 2024. Since PrEP was commissioned by the NHS in autumn 2020, the number of people accessing this prevention tool has increased annually. And in 2024, there was a 7.7% increase in people accessing PrEP, with now just over 110,000 people receiving it. And we also see an increase in HIV testing rates. Overall, HIV testing in sexual health services has increased by 3%. I should add that in addition to the every 2-month injection for prevention, you may also have seen press around an alternative injection called lenacapavir, which has also been shown to be effective for prevention of HIV acquisition. At the moment, this drug is not commissioned in the UK. It has a quite exorbitant price. There is some licensing that's going on for low and middle income countries to use this as prevention, but I think we're some way off having access to this prevention technology in the UK. So what do we see in terms of the proportion of people testing HIV positive in key adult populations? Well, you can see the breakdown here in England between 2019 and 2024. In ethnic minority, gay and bisexual men in green, this is the top curve here. And then you can see the rates in other groups in the other colours listed. You can see white, gay and bisexual men in the sort of navy colour, which is the second one up from the bottom. So what we see is some disparity, even in gay and bisexual men who have sex with men, in the rates of HIV acquisition. And clearly some of the benefits we've seen around prevention, regular testing, and the knowledge that being undetectable in terms of your viral load in blood when you're on HIV treatment, meaning you cannot pass on your virus. This is known as U equals U. We can see these benefits have affected all populations, but in particular, it seems to be white, gay and bisexual men who have benefited more than ethnic minority gay and bisexual men currently. What about other sexually transmitted infections? These are the number of diagnoses of chlamydia and gonorrhea that are seen among gay and bisexual men who have sex with men accessing sexual health services between 2015 and 2024. So we can see these rates have gone up quite markedly, certainly for gonorrhea, a small uptick for chlamydia, but quite high rates of gonorrhea in this particular population. In terms of other sexually transmitted infections, syphilis, genital warts and genital herpes, we can also see some increases, particularly for syphilis, although you can see the rates of genital warts and genital herpes are either stable or have in fact dropped. And perhaps this is the impact of HPV vaccination with regard to wart development kicking in and reducing the rates of genital warts that we see. So syphilis and gonorrhea are a particular problem in GBMSM. We have opportunities when these groups attend sexual health services to talk to people about living life healthily and give them other advice around behaviours that may be harming their health, including tobacco smoking. So what are we doing about syphilis and gonorrhea? Well, just this year, the UK has launched the world's first rollout of meningitis B vaccine to combat gonorrhea. This is not overly effective in individuals, but the idea is to increase population immunity so that hopefully rates of gonorrhea overall will go down. So at an individual risk reduction level, the vaccine seems to reduce the risk of gonorrhea by about 40%. At a population level, we hope by reducing by 40% will of course reduce onward transmission and reduce gonorrhea rates overall. What else are we doing for bacterial sexually transmitted infections? We have another form of prevention. This is called DoxyPEP for reduction, in particular, of syphilis and of chlamydia acquisition. So DoxyPEP is a treatment for STI prevention. What this means is that people can take the antibiotic doxycycline after sex to prevent getting an STI. And studies have shown that taking DoxyPEP reduces your risk of getting syphilis and chlamydia by about 2/3, especially if you're a transgender woman or a man who has sex with other men. So how to take DoxyPEP? You take 200 milligram tablets of doxycycline, ideally within 24 hours, but no later than 72 hours after condomless sex. And if you have sex again within 24 hours, you take another dose. And we now have national guidance from the British Association of Sexual Health and HIV around the use of DoxyPEP for the prevention of syphilis in particular, but of course for reduction of chlamydia as well. So these were the UK first guidelines. They're accessible via the BASH website for anyone who's interested. We're seeing increasing rates of people now using DoxyPEP to reduce their risk of bacterial sexually transmitted infections, alongside HIV pre-exposure prophylaxis to reduce their risk of HIV acquisition. So what about smoking? Well, Michael's touched on this already. We know that lesbian, gay, bisexual and transgender people are more likely to smoke than the national average. And many within LGBT communities also report barriers to accessing medical treatment. So as we've heard, services must therefore be inclusive and welcoming to LGBT+ people. As I've said, people are more likely to smoke than heterosexuals, and we saw that very nicely on Michael's graphs. Rates are particularly high for LGBT women and bisexual men. And we know that there is sometimes an absence of robust data in smoking in transgender people, but with the better response to questionnaires that Michael's demonstrated, we do see that there is an increased rate of smoking. And I think we get better data around that as we see more people being willing to answer these questionnaires more fully. In terms of additional vulnerabilities, again, as touched on in the previous talk, we know that LGBT people are disproportionately affected by wider social inequalities, which can increase the risk of smoking initiation and tobacco addiction. We know, for instance, that younger LGBT people are more likely to be homeless, and there's research, of course, linking being homeless with a higher risk of smoking, suggesting that as many as 77% of homeless people smoke. We've also already seen that people from LGBT groups are more likely to experience mental ill health, and we know that people with a mental health condition are also more likely to be smokers. And we've heard mention that people in the LGBT community are also more likely to use other illegal drugs, and high rates of smoking are often found among those using other substances. So within sexual health services, what can we do? In addition to face-to-face advice, we now see in our sexual health clinics the ability for people to access the Smoke-Free app. This is available within London and free for Londoners, and offers online text and helpful support 24 hours a day, online guidance and advice, allows people to check in about their journey with smoking cessation, and also offers free nicotine replacement, which is able to be delivered for people who choose to access this. So overall, I think at a time of testing in sexual health clinics, at a time when people come forward to talk about their sexual health, we have an ideal opportunity to talk to LGBTQ+ populations and individuals about smoking cessation to increase not only their short-term health, but also their long-term health and their overall health-related quality of life. And we aim to encourage people to not let tobacco define who you are and to live tobacco-free. So in summary from me, the LGBTQ+ community is not homogenous, but there is an increased risk of sexually transmitted infections and bloodborne viruses for many. Combination prevention approaches have reduced HIV rates, particularly, we should note, in white, gay and bisexual men who have sex with men, also in other groups, but perhaps at the moment not as maximally as we would hope for. Doxypep is now widely used and should help reduce STI rates, in particular syphilis and chlamydia. And whilst taking care of your sexual health, there are opportunities to think about the wider health positive actions you could take, including smoking cessation, for which help is available. So thank you very much indeed for your attention. I look forward to our discussions later, and I'll hand back to Tracy.
Thank you so much, Tristan, and to you and Michael. You've really set the scene here as to why we're here today talking about this issue, what the drivers are, and we haven't got all the solutions, but what some of the solutions are to some of the health issues, and how we do have support for Londoners. And Lou and Rose are going to talk about how the Smoke-Free app is friendly to LGBTQ+ populations. So I think that's incredibly helpful to frame that. So are there any questions, please? I think people will probably have to put them into the chat. So because our people on the call are muted. So any questions, please, to go in the chat. I suppose before we do that, I have a question around kind of those other issues. So if someone comes in and you're addressing their sexual health, and then we've got issues with smoking, with alcohol, with chemsex, etc. How do you break that down so that someone isn't overwhelmed by all of this stuff that would be supportive for them? Because we're going to hear, we hear from some of our population later, the community is very strongly social, and many of those things are embedded. So just wondered if you had any thoughts on that.
Yeah, I'm happy to jump in with that. I mean, I think the priority really is finding out what's most important for an individual at each consultation, and having that re-engagement so you can revisit other lifestyle modifications later on. So for many people at a first attendance, the priority might be accessing PrEP for HIV, getting some STI tests, getting their blood tests done. And they may, as you say, not want to be overloaded with other lifestyle advice at that point. But certainly with PrEP, people need to come back for monitoring. They need their kidney function checked. They need to come in for regular STI, HIV, and other bloodborne virus testing. And at those repeat attendances, I think that's a good time to pick up on other things that may be affecting their health overall, and offer them help and support to address those issues if they're ready to. I don't know if you feel the same, Mike.
Yeah, I would agree. I mean, I think in the sexual health or HIV setting, the challenge is many of the people that we see, we don't necessarily see as regularly as you would need to build up that relationship and to address things over a period of time in the way that Tristan describes, certainly in sexual health. That PrEP users is a particular opportunity because those are people who are regular attenders, and particularly often when they're stable on their PrEP, you've got a bit of time in a consultation to cover other issues. I think this perhaps touches on the question from Marina in the chat as well. I mean, I think probably it's fair to say that smoking cessation and interventions, or even robust history taking, is patchy and poor, I would say, in sexual health services. It's good in our HIV services, and I think, but again, probably because of that ongoing relationship, a bit more time. Many people, only a small proportion of their consultation is going to be focused on their drugs or their HIV, and actually a greater proportion on their mental health, their chemsex, their smoking, their alcohol. So I think we're better in that setting. But I think, as we've highlighted today, the sexual health setting, for many reasons, because of these interrelated demographic and behavioral and mental health risks, it's the right place to be at least focusing some training, some awareness, some signposting, and that's another reason why the app is great. It doesn't take long to note someone smoking and to signpost them to an app in a busy consultation.
And I was about to make that point, which is that we now healthcare professionals are busy, and so if you want to give them something, actually, now that we have the smoke-free app across the whole of London, that is one thing that they can take away. And our evaluation of it is people are using it round the clock because they've got access to live advisors round the clock. And also, interestingly, some of our data showed that there was a slightly higher proportion of people identifying as LGBTQ+ in the users of the app. And some of that may be around reduction of stigma, anonymity, but also it is 2025 and we do want stuff 24/7, and it definitely provides that. So Liam's going to talk later and show some of the posters that have been flyered and distributed widely across sexual health services and other venues in central London. So that's great. I'm just looking at the there's another question here, and Lou, of course, has, from the National Centre for Smoking Cessation and Training, has said she would be happy to deliver a session separately that may be tailored for this population. And then, where are we? There's another, sorry. So there's a question about overlap of LGBT and homelessness and poverty or data poverty. What alternatives are there to the app? Well, most boroughs in London now have a face-to-face service because additional money came into the system 2 years ago. So there are services there. They may not be the ideal service for someone who is homeless. We do still have to think around how we deliver non-digital solutions. But what I would say is, now we have a digital solution, actually many of our face-to-face services can concentrate on specific populations that aren't going to be in that main group who use the app. But having said that, we have people from all socioeconomic backgrounds who've been using the app, so it is wide. But I think it is an opportunity for local services to think about how they may address that. And Lou's just said thank you, that there's a module on supporting people experiencing homelessness. Thank you.
Maybe I can take Roz's question about dosing of medications.
Yeah, lovely, thank you.
Thanks. But just read it out for anyone who doesn't chat, but there's an awareness that dosing of some medications to people with mental health can be impacted by them quitting smoking, and whether the medicines I mentioned in terms of PrEP or doxypep need to be modified if someone is planning to quit smoking or using varenicline or I can't see that word, cysteine, to help them quit. And there's no modification required for any of the PrEP, the injectable PrEP, for the oral PrEP, or for doxypep in addition. I was just thinking, Michael, that I remember that we used to have a very good opportunity in sexual health to talk to people about smoking, because we know that smoking affects genital immunity. And we used to see some people, when we had high rates of warts, particularly, they were very difficult to treat when people continued to smoke. That used to be a real lever. We've now fortunately seen a reduction in warts, but I think there is some evidence that shows that continuing smoking for people who do have recurrent or persistent sexually transmitted infections can actually make it harder to treat those, or make it more likely that they become chronic. So sometimes there are other levers to get into the smoking discussion.
That's really true, and I think that historical remembrance of much higher rates of particularly persistent warts, which we are, as you're right, we are seeing a lot less of because of HPV vaccination, but that remains in people's heads. So actually, I think that is about the only time probably that the staff in the sexual health clinic consistently ask about smoking and recommend smoking when they see somebody with genital warts. So you're right. That's a very good hook, because we still see a lot. Gets people thinking about it, at least.
And the question about asking smoking status is not just confined to sexual health services. It's a universal issue that would be something that would be game changing, really, if everyone were consistently asked, because actually we now have a universal offer that people can have if they choose to access it. So thank you. We're getting some really interesting discussions here. So any more questions? I think one's just gone. Marina, the app has lower quit rates than the local service, and it's still essential that groups with higher rates of smoking access the in-person service. Yeah, I would agree with you. I think you've got to have a number of different approaches. One size does not fit all, and we need to offer a multiplicity of ways to support people to give up. So you make a good point there. Any more questions? No. Well, thank you both very much, and I'm sure there may be other questions that emerge later, but we are 1 minute ahead of schedule, so I'm extremely impressed. Thank you both for that. And we're now going to, in fact, Liam and I are now going to talk through how we've developed this campaign, and to show you and share with you some of the campaign materials. So I can't see you at the moment, Liam, but I'm sure you're there.
I am here. Trust me, it's better without seeing
me. No. So I think you're going to start with the survey of Lambeth LGBTQ+ communities, Liam, yeah?
Yeah, I just thought it'd be really interesting. So we did a localized survey, LGBT Hero did a localized survey in 2022 on behalf of Lambeth Council, which was focusing on the lives and health of LGBTQ+ people in the borough. We surveyed around 562 people, specifically 562 LGBTQ+ people, about their mental health and well-being, including their relationship with drugs, alcohol, and importantly in this case, tobacco. We found that around 18% of people had smoked cigarettes or tobacco in the past 12 months from taking the survey. And of those, nearly a third reported smoking every day, suggesting a high level of dependency amongst regular smokers. We also see that 47% they said they smoke at home and 41% smoke when they drink, which may reflect the social and environmental context in which smoking takes place. Now, 54% of respondents describe their current mental well-being as only fair or poor, and it's this connection between smoking and mental health that highlights the stress, discrimination, and the minority stress that can all contribute to higher smoking rates in our community. Oh, the campaign, yes. So, LGBT Hero, we held 3 focus groups and we surveyed the community about LGBTQ+ stop smoking messaging and imagery to have a greater understanding of like the tone and aesthetic that resonates with our very diverse community. Then we sat down with Stop Smoking London to interpret the feedback and help develop the UK's very first targeted stop smoking campaign for LGBTQ+ people. Hand to Tracy.
Thank you. And so we tested out a range of different images, color palettes, etc. And people really wanted something that was vibrant and bright and didn't look like a normal, a standard campaign. So we developed these and tested them back out with the community. And then Liam very kindly put a call out for people who would be willing to share their story of giving up smoking. And we have 3 of those stories on our website. I'm just going to share this one, which is Miguel. And can you tell me if the sound plays? Because I haven't got the sound share.
No sound for me.
Okay, sorry, I think I have to come out. Apologies about that. So I will share again and include sound when we go in. There we go.
I'm Miguel and I work as an artist in the events and I live in West London. Yeah, there's a picture of when I was 23 years old. This was taken in Spain, smoking, trying to be cool. I started smoking when I was in secondary school. From there, I ended up smoking when I went to uni. Cigarettes was a part of my life. It was like when I wake up, I need to have a cigarette. After my breakfast, I need to have a cigarette. I will have a cigarette with coffee, tea, or whatever it is. I'll just need to smoke constantly. I used to smoke up to 20 cigarettes a day. It depends if I'm going clubbing and partying and all that kind of stuff. Yeah. When you go to a pub or to a bar or to a club, you go to a smoking area and people will be talkative to you. People will be talking to you. And this is where you actually meet people. It's the socializing part is what actually triggers people to smoke. I decided to stop smoking when I started to feel that I got health issues. When I used to go to the gym, when I'm lifting weights, I'd be like struggling to breathe. So I said, right, I'm going to try to stop, cut down this and see how it works. I did actually try heated tobacco. It's still cigarettes. It still had tobacco in it. They say there's no difference between smoking that and actually smoking a cigarette. And then after I went to vape as well, it still has nicotine in there. Just had no nicotine in my body. That's the thing that I decided to do. And when I completely decided to stop smoking, I can breathe normally. I can lift more weight. I feel that I had more energy actually. I sleep better, save lots of money. My skin and everything became really good. My advice is if you can't do it by yourself, there's lots of help out there as well. There's apps. You can even call to places where you can seek help for stop smoking. I know it's not easy because if you've been smoking for a very long time, it's a hard decision to make. It's the challenging part, I would say, is going clubbing, partying. It's difficult, but you can still do it without smoking.
So that's a very powerful story from Miguel. We've got three stories of people from the community who have shared their stories, which are all on our website. We have got a landing page for the campaign, which hopefully one of my colleagues will put into the chat. Hang on. So really now going on to some of the other parts of the campaign, emphasising the fact that there is a higher rate of smoking in this population. So again, we work with LGBT Hero to think about how we could develop some of these assets, and also really trying to get over the message around smoking and stress, that actually some of the withdrawal from nicotine can make people feel more stressed, and then the nicotine relieves that stress, but actually it's the nicotine which is increasing stress as people go between smoking various go between smoking and as the levels of nicotine fall. So this is another story we're going to share.
I'm Sue. I live on the south coast of England now, having spent a long time living in London, although, as you can tell from my accent, I'm from Scotland, specifically Edinburgh. And my various careers just took me to London, where I worked hard, played hard, smoked a lot, and then quit, and I have a rather different life now. And I started in my late teens, I think about 18, I was a student at university, and it became part and parcel of daily life and social life. And I think one of my themes with smoking is that I think I was very much a social smoker, but a real smoker. I mean, I smoked a lot as I went through my 20s and my 30s. I do a lot of night clubbing, pubbing, and certainly on the gay scene in those days, everybody smoked. And then I got really unwell. I remember I couldn't work actually for a couple of weeks, which was very unusual for me. And I had a really bad respiratory infection, just felt dreadful. And I just decided to stop. I think physical health really mattered, actually. I think I didn't want to be ill. I didn't want to be compromised constantly. Maybe some other part of me just sort of knew if you keep smoking, you're going to really, really become ill. A few years on, later in my 30s, I had been frightened of water, but then I started, I'm going to learn to swim, and within 2 years I went from quite scared of being in the water to a master level swimmer. And of course, if you swim with your face in the water, you've got to have pretty good lungs for that, you know. So it's another really interesting step that came from that, because if I'd still been smoking, would I have done that? I doubt it very much. I just don't, physically I wouldn't have been in a state to do it, I don't think. And I've talked to a lot of people about this, about giving stuff up. You have to really want to do it. And yes, there are loads of support that can help you get there, that's for sure. It ultimately truly has to come from within you.
We have used images and gone into places where we want to find the community and work with them. So we've got a social media campaign. We've also got our first Grinder campaign, because that's a really, really effective way of targeting the people that you want to send the messages to. So that is running at the moment. We will kind of evaluate how this is working and how many people we've reached, and can we see if people have downloaded the app, etc., how many people have been on our landing page. We're getting very positive comments on social media as well. So we will evaluate this and then think about what we may need to do to develop it further for a future campaign, and also to use this. So this is we've developed materials to use this week, but how can we use these materials through the years, so we're not just concentrating on 1 week for this particular population. Liam, did you want to add anything to that?
Yeah, just I saw Julie's comment. There are leaflets without the LGBTQ+ week branding, and they will be distributed by us throughout the year, so we continue to promote the smoke-free app to our community.
And apologies, if I can share this slide, I will, because Liam's done a fantastic job of focusing the LGBT Hero. Here we go. I think this will work now. The LGBT Hero newsletter and magazine around this topic. So, and also we have got flyers out in Soho, in sexual health venues, in parts of London where there are a high proportion of LGBT venues. So this is just to share really what that looks like. And then this is FS Magazine. Do you want to talk through that, Liam?
Yeah, we put together a so FS is our Health and Life magazine for LGBTQ+ people. It comes out every 2 months. It's digital. It used to be physical. Sadly, we had to let go of that one. But we did a dedicated issue to the LGBTQ+ week with articles exploring the links between smoking and mental health and smoking and alcohol. And actually, you can read the article on the screen here, Smoking and Your Mental Health, on our Instagram page in full or on our website. Thought I'd get that plug in.
Absolutely. Thanks, Liam. And I talked about our Grindr campaign. These are our specific Grindr adverts. It's, as I say, it's not a place where we have traditionally put ads and tried to encourage people to download the app. We are getting very good engagement, very high percentage of click-throughs from that. So again, we'll continue to see how much how effective we can make that. And then the other thing is that we are directing people to their local support. Marina obviously highlighted that there are local services as well. And on Stop Smoking London, we do have a way for people to find their local service and get in contact if they would like a face-to-face or sometimes telephone or other services. So that was just really to highlight the campaigns and some of the services that are available to support it. I think there's another question or comment in the chat. Who commissions? Have we tested the messaging as well as the yes, we tested all of that, Marina, because we wanted to make sure that it was going to have an impact. And any other questions? Just looking now. Yes, and it is possible. So that's Julie's question. Can you have the assets with the date removed? We've done those already so that they have a longer life outside of the week. So that's great. Right. Any more questions? Apologies for that technical issues. If not, I'm very, very pleased, absolutely bang on time, to introduce Lou, Ross and Rose Pink from the Smoke Free app, who've also done some really good videos for us. Thank you. And they're going to talk about the Smoke Free app and how it works with the LGBTQ+ community. Thanks. And I think Rose is going to do most of this because of your dog issue. Is that correct?
Sorry, it's the building work as well, and the smoke detector's been going off. So I'm going to apologise, and Rose will do a splendid job, I know.
Oh,
thank you, Liam. Over to Rose.
Thank you. So I do have my slides, so I should be able to share these now. Can everyone see them? Yes. I'm going to take that as a yes.
That is a yes.
Perfect. Thank you so much. So if anyone saw me yesterday and you said, aren't you wearing the same brown jumper as yesterday? No, it is a different jumper, just to start off. So me and Louise Ross are going to be talking about the Smoke Free app and building bridges with the LGBT+ communities. So I am Rose Pink. I'm a registered mental health nurse working on the Smoke Free app, and I'm out and proud transgender woman. And Louise Ross, if you would like to introduce yourself, please. I don't know if she's, oh, she is still here. And Louise Ross is our Stop Smoking lead advisor, and Louise has a lot of experience in the field. So we're very lucky to have her, and she is now our business development manager. So moving on. So we've gone over some of this already, so I'm just going to touch on it briefly because I just think it's really important to reaffirm some of these points. So going on a national basis of people that do smoke, so over 1/3 of people, so 3/4 of people who smoke, so they'd actually like to quit smoking, but only 1/3 of those people go on to make a quit attempt every year, and about 5% of those people quit successfully without support. LGBT plus people, as we know, have been targeted by tobacco companies throughout history. Going back to club events, they specifically aim to market towards LGBT plus people to encourage them to undertake smoking. And once you're hooked, you're kind of hooked, and then getting off it's a lot harder than getting on it. And then you've probably seen this table a few times, but the smoking prevalence by sexual identity in the UK, as you can see, there is a large increase for those that smoke amongst LGBT plus communities in comparison to a cisgender and heterosexual society. Smoking rates in LGBT plus communities. So there's, again, many factors that we've touched on, such as stigma, fear, hate crime, that sort of fear. I have fear walking down the street late at night because I don't know what's going to happen. And I know that a lot of my peers probably experience that too. And that constant stress really does weigh on you, and it does increase your likelihood to smoke because you are stressed out and you're looking for something to take that edge off. Along with socialization and isolation and homelessness, as we touched on with the Albert Kennedy Trust, there are specific trusts highlighted to encourage that sort of uptake of, well, discourage homelessness in LGBT+ communities. And homelessness, as we know, is another factor that encourages smoking. So those two go hand in hand because of the discrimination some people experience with their families. Maybe they get kicked out because of their queer identities. And so, yeah, it's just important to highlight that and recognise that there are differences that really do lead to this increasing in smoking rates amongst LGBT people, along with alcohol and substance misuse as well. Barriers to care for LGBT+ people. They won't understand people like me. They won't get the stuff that I'm dealing with. They can't make the clinic times. And people might make assumptions about their lifestyle. So these are just some key thoughts that I relate to, and I thought other people in the queer community do relate to as well. And it's just that lack of understanding. We know there's quite a disparity in healthcare services really having an understanding of queer and trans issues. People feel that they're not going to be understood because most people that understood are people in the community. You know, we reach out to other people in our community to get that understanding because we need that sense of community and solidarity. And when you go to a health service where some of the people might traditionally, not always, but some of the healthcare professionals might be heterosexual or misunderstanding of these issues, you get met with this barrier, and it really creates this feeling of disconfidence in yourself. You just don't feel good about it. So that's where we come in for the Smoke-Free app. So we are looking at building bridges. So the main thing about us is we're really accessible and we're in reach to our clients. So we are available all day, all night, every single day of the year, Christmas Day, New Year's Day. There is always someone there that can talk to you. This is especially good for people that maybe work night shifts, outside of business hours. So a lot of our clients do access the app between 5 p.m. My dog just barked. I don't know if you heard that. Just ignore her. Between 5 p.m. and 9 in the morning, we do have a lot of people accessing the app and speaking to the advisors. There's a lot of features in the app that meet different needs. So we have, I'll talk about some of the features later, but they just meet a variety of needs. Our advisors are non-judgmental. We have a non-judgmental approach, as most smoking cessation advisors do. You are, taught to have a non-judgmental approach, but specifically with our team, we are very non-judgmental. We're real people and we're empathetic, and we use evidence-based products. So again, I will focus more on that soon. The London Tobacco Alliance campaign video. So me and Lou got invited, and we're very, very excited to be involved in this. Again, I didn't actually put in the video. I did get tempted to, but I thought it's actually way more exciting if you listen to me talk about it. So that's what we're going to do instead. So you can look at the videos on the YouTube channel Stop Smoking London. I believe the link will be put somewhere in the chat. But the main points from the videos is that we spoke about what the Smoke-Free app is, why it's important to us, and why it's needed to focus on LGBT+ communities. So Lou raises a really good point, and I love this quote. And it's basically calling the Smoke-Free app an advisor in your pocket. That is the best way to describe it. The 24-hour support, being able to access it anytime you want, and just having that advisor that you would have in a smoking cessation service just through your phone, and you can talk to them whenever you need to get that support. It can really help with cravings, for example. If someone has a craving, they can get a response from an advisor within those 2 minutes and speak to someone about it. It's a customized approach, so it's that person-centered care element where we really try to shape it into what the person needs based on their needs. And we recognise that everyone has individual needs that are very different to another person, and we will customise our approach to meet that person's needs. We have a drive to reach LGBT+ people. Me and Lou are very driven to really promote the need for this minority group, and we really want to make sure that we are encouraging more LGBT+ people to uptake the app and speak to us, you know. As well as that, we have an understanding of the need, because we have experienced these issues in society with being LGBT+. And so we have that understanding, and we can actually teach that to our advisors and make sure that is maintained in our team. The history with LGBT+ issues and the ongoing battles. So as said, you know, LGBT+ people were targeted by tobacco companies, and we are aware of the history and how much struggle. I mean, like 55 years ago, it was illegal to be gay in the UK. It's the progress that we've made over the years has really developed, but it's also important to recognise it's not over, and that whilst we are improving most of the time, it's sometimes a bit of a 2 steps forward, 1 step back. You know, there's the recent ruling with the Supreme Court and the gender identities with bathrooms. And it's just important to recognise that this is still a really prevalent issue, and it's something we're really passionate about, because we really want to support our community to reach a smoke-free life. And yeah, they're guided and trained by people with lived experience, us. So choose smoke-free. Why should you choose smoke-free? So with smoke-free, why we are specifically good for LGBT+ people is there's the ability to remain anonymous. So you don't have to disclose who you are per se. You can access support under a synonym, under whatever name you would like, a preferred name, or even just a random name. And that ability to remain anonymous can really encourage the uptake, so that people don't feel like they have to disclose themselves. If you say my pronouns are she, her, they're going to call you she, her. If you say they're they, them, they're going to call you they, them. You know, we aren't going to make any judgments based off looks. Not that we would anyway, because again, we try to really encourage our team to be non-judgmental. Statistically, more people of genders outside the binary use us than local stop smoking services. So I think this was touched on earlier by Tracy, but we did a study, and we're still evaluating the study, still getting on with it. But we did a study about the first 2,500 users that used the digital smoking cessation service with the smoke-free app. And I think it's about 3% of users were found to have a gender identity that's classed as other, rather than male or female, so outside the binary. And that in a local stop smoking service is about 0.3% for the first 3 quarters of the year. So it's a 10 times increase. So it's just really important to highlight that we are meeting these communities, and we're trying to really push it, that we are getting there. Chats are monitored. So as well as the next point, the whole team are at your fingertips to diverse needs. We are all sort of chiming in where we can. And if a user has a specific issue, we can liaise with a specific advisor that might have more experience in that issue. So for queer stuff, I might be tagged in, and I can really help support with that issue. Same as for other minority groups, such as language barriers. We have advisors that speak specific languages, can really support those clients that maybe don't speak English. The app features. So the main thing we really want to hone in on is that it's free. It's free for your clients. So they get a 6-month unlimited 24/7 access to advisors, and they're NCSCT trained. So it's all very professional, and it's all very effective. As well as we send out evidence-based products such as nicotine replacement therapy, patches, gum, lozenges, all of the rest, and a stop vape with liquids. And that is usually a 12-week course if the client chooses to uptake a 12-week course, and that's what we encourage. But yes, evidence-based, as well as the upcoming POMs. So POMs is prescription-only medications. So we are looking at, with specific local authorities, maybe to encourage varenicline and cytosine uptake. So that's very exciting. So stay tuned for that. There's some other features such as the AI Quick Coach chatbot. That is, I believe it's NCSCT approved, isn't it, Lou? Or there's something around it being approved. Yeah, it's been researched and it's shown to be effective if it's used. Community chat room for peer support, constantly upgrading progress indicators of the time smoke-free and the money saved. People do like to see how much money they've saved and how long they've been smoke-free to the second. And there's some badges as well to keep people motivated to do the badges, and you get like a mission every day and you feel quite accomplished if you do that mission. It's like write yourself a letter and tell yourself why you've quit smoking, all that sort of really positive stuff, but it encourages it with badges and really cool images. And then we'll just touch on this quickly because I know I'm running low on time because I'm a bit of a talker. So misinformation and smoking cessation, it's that whole thing of there's tons of health problems that people believe are associated with vaping. And we just sort of want to hit it on the head and myth bust it and say some of it's not anywhere close. There's this constant thing with vaping. Every day we must get it about popcorn lung. Oh, it's going to cause me popcorn lung. And just to say that popcorn lung was actually found in a group of factory workers that were exposed to a chemical called diacetyl. It has not been associated with vaping. Sorry, my dog is going crazy. The door knocked. Don't know why. The popcorn lung is not associated with vaping. It is associated with a group of factory workers that are exposed to a fume called diacetyl, and that is the main takeaway from that. Nicotine is predominantly safe. So nicotine is predominantly safe, and vaping is shown to be at least 95% less harmful than smoking due to the lack of carbon monoxide and tar, which are the two main things that cause health problems. And as LGBT+ people ourselves, we endorse the smoke-free app. So yeah, that is the main thing. And then we don't really have time for questions, but we will have time for questions at the end. So do stay tuned and thank you for listening.
Rose, thank you very much, and thanks for being entertaining as well as informative. That's really, really helpful. Thank you. Liam's had to go. Oh, thank you for the feedback from Annette, which is the Facebook post around LGBT in Bromley was really well received, so that's great. Thank you. And again, we are 1 minute ahead of schedule, so I'm very impressed by colleagues on this call this afternoon. I'm going to hand over now to Julie Calsey, who works at the London Borough of Merton, who gave some small grants out to communities as part of the new money that flowed into smoking cessation within London. And thank you, Julie, for giving us an overview of that work in Merton.
Thank you. And now pressure's on to stay on time, isn't it? And I have no dogs, I have no knocking,
Fantastic.
I have no fire alarms, hopefully, or smoke alarms. So I hopefully will get through this. So as Tracy said, yeah, I work in public health in the London Borough of Merton. I'm here today and I'm sort of representing Merton Plus, who are the local LGBTQ community charity, who are one of the recipients of the grants. So unfortunately, they can't be here today. They are all volunteers. They all have day jobs and very busy people. So apologies that they can't be here, but hopefully I will represent the work that they've been doing as well as possible. So very just quickly, brief overview. We have around 6,000 residents in the borough who have identified as lesbian, gay, bisexual or other non-heterosexual orientation. That's around 3.4% of the population, which sort of lines up with some of the statistics that were quoted earlier, but probably underreported, we think, because the information is slightly out of date. And again, we've covered on this slightly. So in Merton, we have an overall smoking prevalence of around 14%. That's slightly higher than the London, which is around 11%. But as we've spoken before, in the LGBTQ, in some cases, that's almost double the prevalence rate. And we think that's around 1,500 smokers from the LGBT community in the borough. It's small numbers, but it does make it more challenging for us to be able to engage with them. And they're around 7% of our smoking population. So what we did is in Merton, we used some of our local authority Stop Smoking Support Fund grant. So for people that don't know, every local authority in the country has been given some extra funding to be able to deliver additional stop smoking services and to promote stop smoking services. The grant funding is 5 years. I think it's 70 million overall across the country has been shared out. And so we used last year, we used some of our grant funding, 35k of it, and we matched it with some money we had from the alcohol misuse budget. So we had a total fund pot of around 50k. And we did 7 direct award small grants to local community projects, so as well as Merton Plus. We looked at carers first. We looked at BAME Voice, who are an independent body supporting global majority residents. We gave some money to Refuge, who look after residents who experience domestic violence, domestic abuse. Inner Strength Network are a female empowerment organisation, and the Polish Families Association support Polish, Romanian and Albanian communities, of which we have quite a lot across the borough. And just a key thing about the grants was actually matching up with alcohol misuse was really key for all of our recipients, that they I said yesterday, smoking wasn't sexy enough on its own, really, I suppose. Trying to engage with communities just around smoking, it had to be a wider range. It had to be badged a little bit more with general health and well-being and lifestyle. So when it came to the grants, we outlined some purposes of grants and things that they could give. We tried to keep it simple where we could. So we were looking at raising awareness of smoking and alcohol harms and the health harms, raising the profile of the local stop smoking services. And because of the extra funding that we've had, particularly in Merton, we've over the last 2 years, we've got newly commissioned services. We've increased the breadth and depth of the stop smoking services that we have available. So we promote the app, but we do have face-to-face 12-week support with NRT. We have Swap to Stop available, so using vapes instead of cigarettes. We also have commissioned Alan Carr's Easy Way, which is a non-pharmacotherapy one-day seminar, which looks at the sort of psychological implications of smoking and supports people that way. So there are various different ways that people can engage with our stop smoking services. As part of the grant, we asked that they took part in training, and so that was the NCST Level 1 VBA+, so that's the Ask, Advise and Act. And we had a local provider who actually delivered that training. We didn't just direct them to the NCST website, which is fabulous, but it was presented to them. It was done as a training session. And then as part of that, we talked about the local services that were available where they could direct people. And we did similar for alcohol awareness training as well. We encouraged people to do bespoke comms campaigns, so we kind of similar to the campaign material here, to people to avoid the NHS local authority looking branding, and so that it looked like it really came from those trusted sources from the grants. And also they could do some of the consultation around the barriers and the habits and the barriers to accessing mainstream services and what would work best for them. When it came to what they could use for the funds, list there, but one of the things just really to highlight is that we did encourage them to make sure that they, particularly as voluntary sector, that they were backfilling staff, that they were paying extra hours for people that went on training. We often expect voluntary sector to do things for free and for nothing, without sort of recognition. And where it was volunteers, we did encourage them to maybe use incentives and vouchers and things like that, so that they could support their own volunteers and workforce. So when it came to Merton Plus, this is what they put in their project proposal. They're quite a new organisation. I think they're about 2 to 3 years old, and they're 100% volunteer-led. But they've quickly become quite a trusted and respected voluntary sector organisation within the borough. So you can see some of the things they did there. They were going to develop a web platform, look at some of their social media campaigns. They were at outreach events. They went to, we had the very first Merton Pride this year in the borough. They went to Mitcham Carnival, which is a big event within the calendar. Farm Festival and various other local community events that were available. And they've also developed sober socials. So these are alcohol-free and smoke-free sessions that they put on for the people within their community, where they also give them a free drink as part of that process, non-alcoholic, obviously. And again, here are some of the things that they did. So when it came to the website development, they created Breathe Plus, which is available on the website. And when I share the slides, you'll be able to have a link to that. And they, again, this is with badging those other health and wellbeing offers. So they had smoking, alcohol and chemsex harms within that, how to improve access to services and sensitive health support, and promoting healthy behaviour through use of the digital tools and sober spaces. So LGBT hero stuff is on there, the app is on there. They can look at how they develop this. So it was really a single point of access with joined up information for them. And then, yeah, some of the outcomes that they've had. So they had 12 social events to date with a reach of around 100 contacts in there and averaging around 8 attendees. They've done some library health drop-ins and they've partnered with other organisations. So via Merton look after our alcohol and substance misuse service, Spectra look at sexual health in young people, and Consaka support older people from African communities as well. They conducted LGBTQ health survey for us, and they also, as you can see, all 11 committee members trained in the smoking and alcohol awareness, and including that NCSCT VBA training. And also just some pictures there as well, but Merton Pride partnership. So they had over 500 people at Merton Pride this year and were out there promoting the Stop Smoking and the other services that were available. Some of the other things, some of the outcomes from the survey here, smoking prevalence here, it's very small numbers that they used, but 26%, slightly higher than we would have thought. We would have expected around 23%. So that was interesting to get that more hyper-local piece of data and information. And actually, with most of our grant recipients, I have to say, and those grants were from £3,000 to £10,000, they weren't a large amount of money. They are actually nearly all had underspend, and so including Merton Plus, so some of that for the legacy of the future is to continue to have more sober socials, keep the Breathe Plus webpage moving and updating them. I've sent them all the stuff today about the new assets that are available. Continue with peer training as well, so cascade some of that LBE the VBA training to have a peer training model, and look at some more of those sort of health and wellbeing events that have been taking place. And then when you get the slides, you'll be able to click on this and see their quite amazing website. Actually, it's been lovely to see the work that they've done. And we do love their logo. We love the use of the flag and the lungs. We think they've done a great job there. And just really in summary, like the benefits for us for having this small community grant programme, it's absolutely increased promotion and awareness and referrals to our local Stop Smoking service. It might be in small numbers, but we've definitely been able to see that. It's really helped us to establish closer partnership working with all of those smaller communities between local authority and these local community groups. And I think we've got really good value for money. I think what each of the recipients, and particularly Merton Plus, have been able to deliver for quite small funding has been really impressive, and it's been a really positive thing. And I believe I've come in on 10 minutes, Tracy.
You are so amazing, thank you. So we're not only coming in on time, but it's just really important that we do support local communities to be able to deliver this kind of stuff. And as you say, the amounts were small, but the impact and the impact of how that was felt within the organisations was really high. So I think that, I mean, that small grant model is certainly one that definitely promotes this kind of working. And as we go within the 10-year plan into neighbourhood working, I think thinking about, well, neighbourhood, the 10-year plan has got smoking cessation written all over it. It's about neighbourhoods. It's about a movement to prevention, and it's about analog to digital. Now that's not for everybody, but it is the way that the strategic direction is going. So really helpful. Thank you, Julie, and a really good overview of the work that Merton Plus did. I can see there's something. Michael's got to go. Thank you so much, Michael, and really appreciate you coming this afternoon. So, well, we have got time for Q&A at the end. So can I suggest that we segue into Oscar Marino from GSTT, who's going to talk about the work that GSTT, hi Oscar, have been doing with Lambeth Links. Over to you.
Thank you, Tracy. Thank you, everyone. Thanks for the invite for the first ever week for LGBTQ+ community. It's really exciting. I'm getting my slides up. Can you see them?
We can, yes, thank you.
Okay, thank you. Sorry, am I doing the presentation? Is it on presentation setting, or can you just see the slides? I think you should be able to see it now.
That's presentation now. That's
okay, great. Thank you. It just updated today.
That's all right.
Okay, so thank you, everyone. My name is Oscar. I am the lead for the Lambeth Stop Smoking Service. We are part of Guy's and St. Thomas's, GSTT. What I'm going to present today is some basically an overview of the last 2 years of work with Lambeth Links. I have to start by saying that Lambeth Links is the leading organization on this project. They reached out to us to get us involved in this project. And we have created this slide presentation together. Me and Cheyenne worked on it. She presented it yesterday. She did a really great job. So I'll track on and continue with the presentation. As you can see in here, the contents of today, as I mentioned, was first a little introduction to Lambeth Links and to us as the Lambeth Stop Smoking Service, a bit of background on Lambeth and LGBTQ+ smoking data. I won't go too long on that, as we've seen quite a lot of it today. And then I'll delve onto the creative health pilot that we ran in 2023 and the community research project that came after that, the most recent pilots, the pilot number 2, as you can call it, and then some initial findings. Okay, so just to start with, Lambeth Links is a community organization that does advocacy on behalf of the local LGBTQ+ community. So they do this on behalf of anybody that lives, works, or socializes in Lambeth. They do quite a lot of work on that, and part of their work is the health and well-being advocacy and getting involved in health improvement projects. When it comes to us, the Lambeth Stop Smoking Service, we are the local specialist service. We have been around for 20+ years, and we are the tobacco dependence treatment team. Effectively, we're still known in the community as the Stop Smoking Service. We offer the 12-week standards treatment plan for smoking cessation. We work with local residents, and most recently we opened it up to anybody that works in Lambeth. We also join, as any other service, the national campaigns and local campaigns for smoking cessation. And as part of our work, we also take part on innovative projects like the one that I'm going to be speaking about today. I will skim through this because we've seen quite a lot of data today. The only thing I wanted to highlight is that Lambeth has quite a high percentage of people that identify as LGBTQ+. We are the borough in London with the highest percentage that identify as part of the community, the second in the country. And I think the third is actually Southwark, which is our neighbours. So we are in an area with quite a lot of people that identify as part of the community. There's also some other data in there that I'll send the slides through. So you're more than welcome to go through it and make any questions if you've got. I'm happy to answer any questions. So Lambeth Links decided they would like to do a project that would involve an element of creative health, healing through health, and smoking cessation when they had a look at the stats. So they had a meeting with us and with Arts for Space, which is a local arts and crafts organization. They've also been around for many, many years, and they are quite established in Lambeth. We had a bit of brainstorming together in terms of discussing what would be the best approach, and we decided that we were going to create a 8 weeks stop smoking support group. We decided to go ahead with that, and this group would combine the element of art, which was in this case creating a mosaic together as a group, and the element of smoking cessation. So while people were in the session, they had a chance of creating this mosaic while they were discussing anything to do with smoking cessation, how the quit attempt was going, and so forth. We had 3 people joining this group. 2 of them completed the course, meaning that they successfully quit. The third person actually joined the Stop Smoking service months later on a one-to-one basis and actually managed to quit as well. So it was really good to see that even though this was low numbers, we had quite a high engagement rate, and we had effectively everybody managing to quit. And not only that, but they also managed to stay in touch with us for space, the art organization. So that even though at a very small scale, we saw a really positive impact of it. After we did this group, we agreed to have a thought and try to have a more in-depth knowledge in terms of the needs from the community. So as for, Lambeth Links got in touch with Bluegrass and they agreed to do a communities research. This consisted of 10 interviews to local queer people that live in Lambeth or socialize in Lambeth and that are smokers as well. We try to keep it as diverse as possible, as you can see when it comes to divided by age and sexual identity or gender identity. We pivoted around different topics like smoking being an LGBTQ+ issue, which people were not identifying as such. We also spoke about the smoker's identity and how the local stop smoking services could be a way of working with the community. And when we delve specifically onto the LGBTQ+ creative health topic and try to gather the thoughts about what they thought would be appropriate for them, they realized the many potential benefits of having a unique setting as such. So after this research, we took that into consideration and we created the second project, which was delivering 6 drop-in sessions. This took place this year in September and October around the Stoptober campaign, just as a way to try to capitalize on that as well. Lambeth Links did a lot of social media advertising. We, as the Lambeth Stop Smoking service, went around to the queer venues, distributed leaflets, spoke with the people in the venues and kind of raised awareness of these projects and how to join in. Each session was pivoting around a different topic around smoking cessation and at the same time creating a piece of art of their choice. Unfortunately, the turnout was not what we expected. It was quite low, as you can see. Only 2 people attended across those sessions. We tried to offer these sessions in different days and times of the week to see if that had an impact in terms of attendance. It did have an impact in terms of pre-sign up to the session, as this was an option. For example, for the Saturday sessions, they were the ones where we had most people signing up to attend. However, that unfortunately did not make a difference in terms of how many people show up. So some initial findings is that in these 2 projects that we've had, the attendance rates were low, and it's something that we are looking into explore. The 3 organizations, as Lambeth Links and Ash for Space, we do have a commitment to continue doing this work. We would love to continue doing this work together. And some of the initial thoughts and findings that we realized is that there are things that can make an impact on this response or in these outcomes. Like, for example, there has been historically a lack of LGBTQ+ targeted stop smoking campaigns, which can lead to the community, the LGBT community, being unaware of smoking being a problem or an issue, something that has really high rates in the community. Existing research also suggests that the campaigns are largely focused on sexual health. Not much focus has been put on smoking cessation specifically for the queer community. Also, we realize there's no prominent discourse around cultural change, as smoking is still heavily embedded in queer spaces, social activities, So that was another thing that we thought of. And there's current movements towards more LGBTQ+ sober spaces, which is framed around alcohol again, not smoking. And the next steps that we agreed to do was to review our approach, as I said, and any other elements that might have impacted attendance, specifically in these last projects. And yeah, as I said, these are the initial findings, and we're gonna dwell on it in the future. And we are still very happy with the work we're doing with Lambeth Links, and we will continue doing this work with the community. Thank you.
Great, Oscar, thank you so much. And once again, we've been sharing really examples of work done at national level, London level, borough level, and kind of service, and much more locally. And I think it's really important that we just really have some discussions around what works well. And actually, it's good. Everyone always comes to webinars and says, oh, it was brilliant, everything was brilliant. And actually, if it's not brilliant, it's really good to learn from that and to share, you know, if there wasn't engagement, clearly there was an interest in setting it up in the first place. So I think that has great value. So thank you very much for sharing that with us. So I'm going to ask our speakers to just come back on camera and just see if there's any final questions. We have got time for some panel discussion. If there are any questions from those who are, we've got over 40 people here, which is great. Any further questions that people would like to put in the chat? Oh, there's one popped up. Yeah, a question for you, Julie. When asking organisations to develop marketing campaigns, how did you ensure their methods were evidence-based?
Oh, that's a very good point. We done some training with them, so they did come along. We didn't give final public health approval to that messaging because we really wanted to let those organisations, they know their communities best and they know what works best. So we did leave it with them to do that. So a really good example, I think, is the BAME Voice that did a whole piece of work around African folklore and use of a spider, use of a that's quite a well-known spider that's used in African folklore. We would never have thought of that ourselves. So we really have left it up to them to deliver their content. But particularly with the Merton Plus thing, you'll see that it's all trusted stuff that's on there. So we did give overview and help and support to those communities where they did develop their own campaigns, but we did leave it to them. They're the experts in their communities. Yeah,
and there's always that, it's not a tension, is it? There's just always that dynamic of which is what I was saying earlier of you know, hyper local versus what comes down. It's like the translation of the Stoptober assets.
Yeah. And I think similar, what we didn't really want them to look like public health. We didn't want them to look like local authority or NHS lecturing. We wanted it to look like they had developed something, messaging support and signposting for their communities. And I think that's what's come out of it for us.
Yeah, great.
And just respecting those organisations. They're all constituted. They're all, you know, they're sort of professional in the way they deliver their services as well.
Thank you, Julie. That's great and an interesting question. So any other questions to pop in the chat? I've got a question for the panel. What do we do next?
Keep having the conversations. That this isn't a once a year thing. That's what I would say.
No, it's not. And I think that we need to use some of this material as part of our ongoing campaigns at different kind of points in the year. So the next big campaign we'll run will be a New Year campaign, which last year we ran 5 for 25, which was 5 steps that people can take within 2025 to support them giving up smoking. We've been incredibly creative this year and we're having 6 for 26, but it's how do we incorporate the materials that we now have for the community and the materials that we have for mental health and pregnancy into that. Tristan.
Thank you so much. I was just thinking in addition about prevention being better than cure. And
Yeah.
so thinking about we know that smoking rates and alcohol use have dropped in younger people, but nonetheless knowing that there's been specific advertising and there can be norming when you come into your community, thinking particularly perhaps about what work we could do with younger LGBTQ+ people to avoid taking up smoking in the first place, I think would be another area to reach out into.
Yeah. And certainly we're doing work with the London Association of Directors of Public Health, Children and Young People's Lead around youth vaping, and there are big links there, and it flip-flops between youth vaping and smoking, and perceptions of harm are really changing. So there's definitely some work to do there, Tristan. Thank you. Any other thoughts on the panel? Otherwise, you're going to get 12 extra minutes, which is amazing. But any extra final thoughts?
Well, I just want to say thank you for running this. I think that definitely is something that needs to continue. I'm glad we have this forum to share the experiences that we've had around LGBTQ+ and smoking. As I said on the presentation, there aren't enough things out there. There's no national campaign specifically. So I think that this is bringing something, creating conversation that is pretty much needed. So thank you very much.
Oscar, we really appreciate that. Thank you. And thank you for sharing the excitement that we've all had about this week, about it being novel and new and cutting ground, really. So and there is another there's a question coming into the chat. Oh, thank you. That's really appreciated, Laura. There's just appreciation coming through, which we all appreciate ourselves. But I'd just like to say a huge thank you to the panel. This was a really different and innovative, but actually really necessary webinar that we needed, and we do need to keep up the momentum. So we will continue the conversations. Please do drop us any thoughts that you have about additional things that we could include. And huge thank you to everyone on the call who's attended and who's been a speaker. We really appreciate it, and get out there amplifying on social media so that we really can reach far and wide. So thank you.